Hello, hi friends. Welcome today to the next setting session of Endo Masterclass of WDA. Today we have our esteemed speaker, Dr. Sai Kalyan today, and we have my friend and colleague, Dr. Anand Mahota. Welcome, Dr. Anand.
Hi, Dr. Saurabh. How are you?
Hello. Yes, I'm fine. So we have
Enjoying
today
the
an
rains of
exciting
Mumbai?
next session of Endo Masterclass. Yes, yes, yes. Not tired of Mumbai rains, actually.
So
So,
let's welcome Dr. Sai
so
Kalyan, sir.
I'll welcome Dr. Sai Kalyan sir without any ado.
Hi, sir. Good evening. How are
Welcome
you?
sir.
Hi,
Welcome to
good
WTA.
evening. Good evening.
So, a brief introduction of Dr. Sai Kalyan, sir, before he kicks off with his lecture. Sai Kalyan, sir, did his master's in conservative dentistry and endodontics from Rural Dental College, Loni, Pravra. He did his master's in advanced oral surgery and implantology from the University of Bari, Italy. He is a board certified fellowship holder of micro restorative and endodontics. He has done his PhD in endodontics. He is a fellow of International College of Dentists, USA. Currently, sir is an adjunct faculty and mentor, Department of Regenerative Endodontics, Terna Dental College, Mumbai. He is the Director, Research and Development at the Prevest Research Lab in Jammu. He is the key opinion leader for Prevest Denpro. He is the member of the Excellence Group and key opinion leader of Silfradent, Italy. He is the director of Indian Board of Micro Restorative and Endodontics. He is a board member of London Oral Restorative Academy. He has fellowship from the International College of Dentists and the Indian Board of Micro Restorative and Endodontics. He is on the editorial board of at least 7 to 8 journals. I can't take their names. Sir has more than 25 publications. He is an author of a book on regenerative endodontics and over 150 workshops worldwide. I was just talking right before we started the session that Sai Kalyan sir is the one who taught me endodontics. हाथ पकड़ के sir ने file कैसे करते सिखाया था because sir was a teacher in the college where I did my undergraduation. So I have the pleasure and honor of knowing sir for the past 15 years, I guess. And
Yeah,
he's an amazing human being and an amazing teacher and a clinician. I still have the fillings which sir had done like 15 years back in my mouth. So stage is all yours, sir.
Wow.
yeah. Thank you.
Yes sir. Thank you sir. We'll share your laptop so that we can begin with the presentation. Yes sir. So myself and Anand will take a back seat sir, and the stage is all
Yeah,
yours sir.
yeah,
Bye, sir.
yeah. Take care. Bye. Good evening, everyone who come here to listen to me on how to incorporate these regenerative strategies for pulpal therapies. We're going to speak about how to incorporate these small things into your dental practice, uh, which would be a plus point for all your practices. Uh, everyone, all my students ask me, what excites you the most? Is this the pulp or those beautiful curves which have been obturated with gutta percha? For me, as long as I can save that beautiful red thing inside the tooth, that is always my first choice. Whenever I can save that beautiful tissue, I would go ahead and save that. Um, when not possible, when it is absolutely not possible to save that tissue, then I would go ahead with replacement. So preservation is always my first choice, and that's my forte. We are now in an era where implants are challenging the whole concept of saving the pulp and saving the tooth. I don't have anything against them. When it is not possible to save the tooth, that is surely a good option to do. But whenever possible, you should be saving the tooth because you don't get better proprioceptive feedback than having a natural tooth inside your mouth. An implant will never give you that proprioception which is needed to enjoy your food or enjoy anything which you eat. Uh, I'm always excited to see cases like this on Facebook where people go ahead and go past normal thinking and then do a beautiful radius section like Dr. Ismail. I think he's from Turkey, an excellent dentist. He has done a radius section here to preserve the tooth in position. I really appreciate this kind of work. This is what I talk about. The primary responsibility we've been taught as conservative dentists and endodontics in India, we call that conservative. So our primary responsibility is to save the pulp and not replace the pulp with an artificial substance. So these are the scenarios which we normally see in a dental department or a dental clinic. But in our 5 years of endodontic curriculum, that is during the bachelor's, we are normally taught two scenarios: restorative and endodontic. This is why we miss all the other interventions, because we are not thoroughly thought about all those other therapies like the pulp therapies, the apexification, apexogenesis, regenerative endodontics, repair of badly destroyed or mutilated teeth, or the preventive aspects are not regularly taught in dental schools. Most of us have learned how to drill and fill, and how to extirpate the pulp and do those beautiful looking obturations. So I'm not going to talk about restorations and endodontics now. Uh, I would be focusing on the other therapies, mainly the regenerative therapies. And I would give you an insight on how you could put these things into your normal practice. Let's start with this case. I always question, do you want to do a root canal therapy or a direct pulp capping in this case? Uh, Honestly, 50 to 60% of all dentists would go with an endodontic therapy in this case, because if you would ask me this question 25 years ago or 20 years ago during the 95s and 2000s, I would also have gone for a routine endodontic therapy, because the philosophy we followed at that point of time is, if it is a pinpoint exposure, we would go with a direct pulp capping. Pulpotomy in permanent molars was non-existent during those times, because we didn't have that kind of material during the 90s. But today everything has changed. During the 90s, when we were in dental school, if this case would have come to us, this was one option we had. This was the only option we had. Do a direct pulp capping with dical, which is a chemically set calcium hydroxide cement. I have nothing against this. This was the best thing available during that period of time. What we used to do is we used to take out all the caries structures, and then apply a thin layer of dry cal. Very difficult material to manipulate. In fact, there are very short setting times. Sometimes it would set by the time we take it inside the cavity and layer the tooth material. So it's a very difficult material. And over that, we used to put a temporary cement. The most commonly used temporary cement at that point of time was zinc oxide eugenol. Um, so that was the cement we used, and then we would retrieve after 3 weeks, look for secondary dentine formation. I don't know how we used to clinically uh, make out whether secondary dentine was formed, but we used to take it for granted that there was some secondary dentine which was formed, and then do a permanent restoration. And that time, restorations were largely amalgam based restorations in India. Yeah, composites were coming in, but largely amalgam based restorations. That was the best possible that time. So talking about temporary restorations, do you do a ZOE after a pulp capping? I would say no, because this is one material which has the maximum micro leakage values. Do you use cavit-like materials in these kinds of scenarios with dical? I would say no. Cavit, I don't recommend using cavit for vital tooth, because it's hydrophilic material. Starts taking some tubular fluid. There are some cases of sensitivity which have been reported when cavit-like materials have been used in vital pulp therapies. So in case you want to do and use chemically set calcium hydroxides, I normally do not recommend. However, if you want to do, you can go ahead and do a temporary cement using resin or RMGIC or a chemically set glass ionomer. that would be a good option. However, we should question ourselves, should we really use chemically set calcium hydroxide? Uh, Now, I don't really think so. Calcium hydroxide dissolves over a period of time, creating those voids between dentine and the calcium hydroxide cement, mimicking those secondary caries kind of lesions. Here, the integrity of the pulp capping agent is lost. So I don't know how good it is going to achieve its intended results. So here, in case you decide to put dical and layer it with composite, uh, when the composite shrinks along with the adhesive, you can see these fine cracks which are produced inside the pulp capping agent, which is dical. By having these cracks, you lose integrity of the pulp capping agent, and thereby the final outcome will also change. So, not a great option, layering dical with normal composites. So if still you want something to deal with this, you can use these kinds of modern technologies where you have resin-based systems with beta tricalcium phosphate and hydroxyapatite-based technologies, which we call it Apacal ART, manufactured by an Indian company called Privis Denpro Limited. It actively releases tricalcium phosphates and hydroxyapatite uh, over a period of time, and calcium hydroxides over a period of time. There's another product, Theracal from Bisco, which has calcium silicates incorporate inside the resin matrix. A lot of people tell me, oh, using these are not very practical. The resin does not allow the active substance to leach out. But the technology has changed. Resins have also changed. Now we have polyethylene glycol dimethacrylate based substances which allow the active material to get out, rather than the earlier versions where the active material could not get out. Here you can see the calcium hydroxide or the calcium ion release from these are in comparison or comparable to ProRoot MTA or any MTA available in the market. So that's a good option. You can just layer, remove all the caries, layer it with light cured tricalcium phosphate based like the Apacal ART or the calcium silicate based resin cement resins, and then etch, rinse, and then layer it with composite and just forget it. There's no need to re-intervene in these kind of cases. So let's see a case which is being done. This is a random pick, exposed pulp here, layered with resin-based calcium hydroxide therapies, and then after curing, it's etched and filled using a normal composite resin. So in one sitting, you finish off. You don't need to wait for 3 weeks, re-intervene like in dical. So it's just fill it, shut it, and forget it kind of a philosophy. Works very, very well. The more number of times you intervene, more chances of bacterial contamination. So here you finish everything in one sitting. So let's take another scenario. This is another scenario which we normally encounter with young people, adolescents, young permanent tooth. They have a fall or just a routine sports injury where one part of the tooth is fractured, some part of it is retained. People get us back those fragments which have been detached. The major problem for this is you can't go for a routine endodontic therapy in these cases, because you can see they have blunderbuss apices. The dentine on either sides are very thin, friable, so they can't sustain future problems. Like if there is a trauma 4 or 5 years later, this will be the tooth first to fracture, since they have very thin dentinal walls. So during my post-graduation days, or the undergraduation days, we used to read about this early attempt of obturating these blunderbuss canals. They're very difficult to obturate. You can't do lateral condensation because the condensation force would just split the tooth into two. So there used to be a technique called the roll cone technique. I think the older editions of Grossman will have it if you're interested in knowing about this. You can use a solvent or heat to just make a rolled cone or just fuse certain GP cones together, and then try it inside the tooth, check for a proper fit and obturate. If it doesn't work, then they used to do a periapical surgery and retrofill it with amalgam. That was the line of thought during the 60s, 70s kind of endodontics. This is changing pretty fast these days. We don't do this kind of replacement therapies anymore. We've shifted to something we call it pulp stimulation, a collective term which is used to describe pulp capping, pulpotomies, epexogenesis, and regeneration. So, how do you do these pulp stimulation procedures? Do you use that original dical glass ionomer kind of a concept? The answer is no. We can't use them because dical, if people have used dical, people listening to me, it's a material which is not hydrophilic. It does not like water too much. You have to completely isolate the cavity, clean up all the moisture around. Even a small amount of bleeding will throw the dical out. So we need a material which can sustain these harsh conditions like moisture, blood, and a material which could be tolerable to all the tissues, that is the pulpal tissues. So, if you ask me what was the most important invention of the last century, there was an online poll, and the winner was Band-Aid. But in case the same poll is taken for dentistry, I would say this material called mineral trioxide aggregate takes position one, because this is one material which allows water, not affected. It is affected, but not much by blood, and it's totally biocompatible and bioactive. So it fits into all the criteria I spoke about in the earlier slide. So this is one material which can be used for pulp capping, pulpotomy, epexification, regeneration, endodontic repair. Every situation there is one. Rather than having 10 different materials to tackle all these kinds of situations, you can just stack one MTA in your dental office. So what is this MTA I'm talking about? MTA is a Portland based cement, very similar to the construction Portland material like your JK White, which is available in India. So whenever I say, oh, it's very similar to JK White cement, they say, oh, why don't we buy JK White cement and use it? Please do not use it's JK White or the industrial grade Portland cement is not pure enough. It has more gypsum content than MTA, so it cracks more. It has high levels of arsenic and lead and copper. The MTA has nil or very little heavy metals inside them. The particle size of commercial Portland cement is not uniform. MTA has a uniform, smaller particle size. MTA cannot be substituted with Portland cement because Portland cements always have variable contents, while MTA, the contents are so standardized. Again, the Portland cements have low strength and they produce carbonic acid, which results in decrease in strength over a period of time, right? So this is why Portland cement should not be used in these kinds of treatments. We stick to the proprietary MTA ones. So when it all started, it was just one company and one man, Mohammad Torabinajad. Dr. Torabinajad created this wonderful material called mineral trioxide aggregate and was commercially marketed as ProRoot by Dentsply. This is what was the first ProRoot. If no one has seen it before, it was the gray ProRoot. I don't think anyone has seen this. So it's mixed with water. So you can see water supplied in an ampule, and this is, it looks very similar to Portland. You can, if anyone has seen someone mixing Portland cement, this is what it would look like. The major problem with this cement was it was too sandy to feel and too sticky. It was very difficult to handle. So it needed some special equipment to take this and then put it into the area of concern. So that's how it's mixed. Okay, you can see the consistency. It's not a putty-like consistency. It's more sandy kind of a consistency, which is difficult to handle. However, this material, this is what we used during our postgrad times. It had excellent biocompatibility. It had numerous number of literatures supporting their claims. It is bioactive. It produces a very good seal. It has a good strength around 65 MPa. It is antibacterial because of a pH of 12.5. Initially, it is around 10. It raises to 12.5 over a period of time. It has good radio opacity. Uh, but the problems with this material, as I said, it has a huge setting time. The initial setting time is around 116 plus or minus 15. You can say 3 hours initial set, and a final set of 1 day. That's 24 hours. Okay. It had poor washout resistance. That means after you put this material, you put a stream of water around it, the whole material gets washed out. So it had very poor washout resistance. So it's very difficult to use in retrofills where you put the material and then you do a rinse before you suture it off. So when you do the rinse, most of the material is washed away. And the problem I spoke about, a very grainy and a sandy mix, that these were the three problems which were there with the ProRoot MTA. Then there came three different materials to solve the issues of the ProRoot. One was biodentine from Septodont, a material which is, I call it a concrete because it has Portland cement based uh, tricalcium silicate, dicalcium silicate base. It is mixed with zirconia and a little amount of resin so that it gets you that putty kind of a consistency, so it can be easily carried. It sits at 12 minutes, so it would be a great material for pulp capping or you can say retro fills where you need faster sets and good washout resistance. There's another material which came called the MTA Angelus. Here, they didn't I mean, they just had one change in the original MTA thing. They decreased the setting time by incorporating calcium chloride. Uh, so calcium chloride accelerates the reaction, and thereby the setting time is decreased. So, however, the grainy and the sandy consistency remained. So this is good again for direct pulp capping. I would not recommend this if you're doing a total tooth obturation with MTA because it sets too fast. You cannot manage the material. So you need different kinds of consistencies to different kind of consistencies to treat different kind of situations. Like direct pulp capping, I would say would require a putty and a fast set. If you're doing an obturation or an epexification which requires a little more amount of time, I would go with the grainy consistencies because it's easier to just push. It gives you some time and all that. So I always wanted one cement which would do both. It would give us a putty consistency when we want and a grainy or a sandy consistency when we require. So the material which I'm talking about is MTA Plus. It has two options, a gel option and a liquid option. If you mix it with water, it would give you a sandy, grainy consistency. So you get more time to get into the root canals, obturate them, kind of, or during epexification protocols, gives you that extra time to play within the root canal. But when you mix it with that proprietary gel, you get a putty type of consistency, which can be easily carried and put over exposed pulps or in retrograde fillings. It has a very good washout resistance when mixed with the gel. So this is the advantage of using MTA Plus. Uh, it can be used for pulp capping with a gel, pulpotomy with a gel. If you need to do epexogenous epexification, you need to use it with gel or water. If you can use it as a sealer when you mix it with the gel, the ratio differs, that's it. When used during endodontic obturation, you can do it with water. And with endodontic repairs, you can do it either with the gel or water. So it gives you that flexibility to play with. I'm not talking anything bad about the others. Yes, they're wonderful material. All of them work very well. So that's the balancing option. Again, you have numerous uh, published articles on MTA Plus, which you can Google and get a copy of them. So this is how MTA Plus is mixed with the gel. On the uh, left, you can see the gel, and right, you can see the powder. The powder and liquid are incorporated using a normal uh, mixing plastic mixing spatula. You can appreciate the putty-like consistency which is obtained at the end of the mix, which you can carry to the site using a normal amalgam carrier. You can see the beautiful fills, how you can take it and get a 3 or 4 millimeter barrier in regenerative cases using MTA plus. So let's take another scenario now. It's like treating the case which I spoke about, yeah, young adolescent with a broken central incisor. So this is the case. We got a 16-year-old patient, a freak incident where her younger brother threw a glass at her and she broke her central incisor. Fortunately, she had retained that piece. So that's the piece which was retained by her. So the first thing we did is make a ditch, at least 2 or 3 millimeter slot, because you need a slot so that you can condense the MTA plus into that. So using proprietary carriers, we carried the MTA plus into the site, right? You can see MTA plus being condensed into the site. And then we had to raise the papilla, raise the gingiva because there was a lot of bleeding. We could not achieve good bonding. And then we used gel foam to control the bleeding. And then we stuck that retained tooth structure, fractured tooth structure, back onto that tooth, right? We gave them a perio pack and then send her back. Um, when she returned back, we reinforced the teeth by adding composite on the labial and the lingual side. Lingual side, we reinforced it using rebond. You can appreciate the rebond on the lingual side. And then that's what was the final result. I would not say it's an excellent aesthetic result, but since we were in a rural area at that point of time, this was very, very much appreciated. The patient were very happy. We could see the patient coming back to us for recalls. In India, we don't get those recalls every time. So we could manage a recall of around 18 months. We didn't see any um, problems or any failures with this case. That's how it started and that's how it ended. That's the 18-month radiographs. Immediate, around 9 months, I think around 9 months, she came back first. And at the end of 18 months, we didn't have any problems with this case. An excellent recall we had, and no problems. We didn't encounter any problems. So if I was a general dentist at that point of time, I would have really gone ahead and done an endodontic therapy in this case. But we were in postgrad at that period of time, so we were encouraged to do these kind of procedures, and we were fairly successful doing all this. So here are a group of cases where the caries dentine was completely removed, pulpal exposures were found, then MTA was placed in a similar way, and then it was layered with composite and left that way. No re-intervention was done in these cases, and these cases proved to be very successful. I don't say 100% success rate in all the cases, but I would say close to 90-95% success rates if you get good isolation. Rubber dam is the way to go. I think after these COVID scares, everyone would shift to rubber dam. So these kind of therapies would do wonders with rubber dam. So we were always questioning us, what do we do? Are there any other ways to save the tooth? rather than other than MTA based direct pulp cappings or these indirect pulp cappings, whatever. So we read an article early during postgrad days on putative stem cells in dental pulp with irreversible pulpitis. So a group of um, researchers had isolated putative stem cells in dental pulp with irreversible pulpitis. So we thought if we can signal this putative stem cells in irreversible pulpitis cases, might be we can avoid RCTs or endodontic therapies in those tooth with irreversible pulpitis. During our days of postgrad, still the concept was if it is irreversible pulpitis, you have to go ahead and do an endodontic therapy. But however, we thought we would do something else to signal these putative stem cells. So this concept, which we thought also was strengthened by this article in 2013, where the Iranian group of researchers led by Saeed Asghari had done a randomized control trials on pulpotomies in permanent molars, something we normally don't think about. Uh, he used a pulp capping material called SEM, and he used MTA also. So he found a success rate of 95 to 98%. Okay, so 98% we don't expect in routine endodontic therapies also, which we could achieve in irreversible pulpitis cases with just pulpotomies. So this is a great article. So we took inspiration from the earlier article, of course. So in 2008-9, we shifted from conventional therapies to regenerative therapies. Team led by lots of colleagues, Dr. Hemlata, Dr. Medgood, Dr. Rahul Wagle, all these crazy people who wanted to do something away from normal. So we started with this regenerative protocols. We read lots of literature, found that this approach was not a novel approach. It was there, right? The leader, I would say, was Nygaard Osby in the 1950s and 60s, where he induced a blood clot in these necros tooth, and then he just filled them up, and he saw that the tooth were responding very, very well just because of that blood clot inside the root canal. So after a period of time, he had removed all those tooth and sent it for histopathology, a practice which we can't do it today because of the ethical concerns. And he saw that in these kind of tooth, he had complete periapical healing. But inside the root canals, he didn't find pulp-like tissue. He found periodontal-like tissue, cementum-like tissue, and bone-like tissue. So that's the histological evidence of what we now call revascularization, and which we claim is very successful. So there's another scientist I should talk about. It's called Nevin. He injected collagen calcium phosphate gel instead of the blood clot, and you can see a wide open apex on the first slide and a completely finished route on the last slide. If someone would publish that now in 2020, I would say, wow, what a result. So these are some historical things which started regeneration off. So we thought, okay, rather than doing bleeding and um, the collagen calcium phosphate gel, we would use a autologous substance, which is known to a lot of people, which we call it the platelet-rich plasma and platelet-rich fibrin. These are two biological substances which are separated from patient's own blood. It's completely autologous, so there are no concerns with this. Uh, Both are autologous and biocompatible. Platelet-rich plasma as well as fibrin release growth factors. Both act as scaffolds, so they allow cell attachment, cell growth, and cell viability. They have a very good degradation curves. Platelet-rich fibrin degrades at the same rate as the opposition of tissue. If the tissue takes 14 days or 20 days to lay on, this would resorb at the same rate. So the degradations curves perfectly match. And both of them have biomechanical properties close to that of the tissue being replaced. That's the dental pulp. So our experiments with PRF in the early stages, we chose some tooth with signs of irreversible pulpitis, yes, and mild periopical rarefactions, not those frank periopical rarefactions. So this is our first case. You can see a class 1 access done, the coronal pulp being removed, and then it's laid with PRF here. We have put a layer of PRF. How to make the PRF, I'll show. Just collect 10 cc of blood, centrifuge it at 400 G for 10 minutes. Uh, it's approximately 2700, 3000 RPM if you're using a 7 centimeter rotor. Uh, the G's depend on the diameter of the rotor. So centrifuge it at 400 G. Uh, then you will see this kind of a thing. In the center, you will find platelet-rich fibrin. So the platelet-rich fibrin is placed inside the pulpal space, and then we layered it with mineral trioxide aggregate. We left it for 6 months, and we could see the rarefaction going away and the tooth responding very normally, clinical and a radiographical success. At 12 months, again, it was asymptomatic. At 18 months, we thought of going with a crown over it because we thought that the restoration would crumble down. We did glass ionomer restoration. Over that, we put a composite layering. So it was a triple seal PRF, uh, over that MTA, and then glass ionomer. Over that, we put a layer of composite. So we thought, okay, the restoration might crack down. So we went ahead with the crown. It 22 months, it was perfect. We uploaded the case in the International Endodontic Journal. We took close to around 2 years for it to be accepted, and we were successful in publishing it in 2012. It took 2.5 years to get this to this stage. This was strongly backed up by the Wang et al. Article. So we could successfully prove that we could uh, signal these putative stem cells using growth factors from the platelet derived uh, substances like PRP and PRF. So we thought, okay, we would do a series of cases to strengthen our concept. So this is another case. Again, access opening done, coronal pulpotomy done, PRF placed, and then here we used biodentine because it could set fast. Okay, same protocol, same success. We were little too overexcited. We did the same approach in over-retained deciduous tooth. Here you can see a over-retained deciduous tooth, PRF being placed, MTA, the same protocol, glass ionomer and a composite restoration to top it all. Same protocol, same results. So early in our journey, we had around 80 to 85% success rates. Once we shifted it to another place where we could fumigate, sterilize, keep it clean, we had higher success rates, close to around 90%. So there's some cases which have been published using platelet fibrin inside the root canals. Uh, I find it often difficult to condense fibrin inside the root canals. However, the cases have been reported and they have successfully reported um, outcomes which were favorable. So again, coming back to the Nygaard Osby bleeding scaffold. So we thought, we would improvise this kind of a protocol using platelet-rich plasma. So we went ahead and did this regenerative protocol in non-vital tooth with open episis. So I will show you one case using PRP. So the case selection in this is we should choose cases with open epices. The epices with an apical diameter of 1.1. This is an old thing. 1.1 was in 2012. Now they say anything over 0.4 millimeter is good enough for revitalization procedure. The younger the age group, the better it is. The older the patient is, the chances of complete recovery are less, because the younger age group has a different regenerative potential. Patient with bleeding disorders are not really for this kind of treatment. The patients should not be on anticoagulant therapy. Patients with history of apical surgeries are not indicated for these, because in apical surgeries we lose something called the apical papilla, which is full of stem cells. During episectomy, we just remove all that structure, so the root completion is normally not possible, because you lose the Hertwig's epithelial root sheath, which is responsible for the root completion. So how do we do this? You do it in two visits. The first visit you do an access opening, remove the necrotic pulp, irrigate it with sodium hypochlorite and ADTA. The concentrations, I'll talk about it. And then place a triple antibiotic paste, which is a mixture of ciprofloxacin, metronidazole, and minocycline for 21 days, and put a temporary restoration with glass ionomer. And then after 21 days, when the patient comes back, irrigate it, place PRP plus a barrier, MTA, and do a triple seal. So I'll show you the case, uh, the whole case. That's what is the case. Okay, young adult, 16 years of age, 17 years of age, in fact, had open apices, reported to us. So we open the access. The access should be wide enough to allow uh, the whole procedure. Don't make pinhole accesses when you're doing these kind of procedures. So that's how it reported. We did irrigation first. So there are lots of irrigants available in the market, but the gold standard had been sodium hypochlorite. Uh, Normally we use 3 or 5.25 sodium hypochlorite, but the literature says that 5.25 or 3% is too cytotoxic for the scap, which is the stem cells of the apical papilla. So it would kill all the stem cells at that position. So you should always be using 0.5 to 1.5% sodium hypochlorite, because this would dissolve just the necrotic debris, and it would not affect the vital tissue. Anything over that concentration would be cytotoxic, and destroy the apical papillary stem cells. So zero point 0.5 to 1.5 is the right concentration. Since the concentration is low, you should increase the activity of sodium hypochlorite by mildly heating it or agitating it. This is what we use. It's an Sonic handpiece. We use it for agitating the sodium hypochlorite so that the effect is faster. So you need to increase the volumes to around 20 ml to get effective disinfection. The second irrigant we use is 17% EDTA. It's really useful because it removes um, all the biofilm, um, basically the smear layer. It chelates, thereby exposing the growth factors which are present inside the dentine. So it does two things. But what you have to remember is the contact time of EDTA. Most of us have 1 minute or half a minute contact time. The minimum contact time required is 1 minute. 5 minutes is the ideal contact time if you're using it in cases of regeneration. That's the evidence we have, minimum 5 minute contact time. Then after irrigating with sodium hypochlorite and EDTA, don't do more of biomechanical preparation, because the dentine on either side is too thin. So most of it should be removed by your disinfectants. So then after cleaning, we put a layer, we put an intracanal medicament, which is a mixture of ciprofloxacin, metronidazole, and minocycline. You can buy tablets of cipro and metro. Mino, you get it in capsules. You have to grind them and then mix them in the ratio is 1:1:1. You can use magricol or polyethylene glycol or propylene glycol to mix this into creamy consistency. When you don't have access, you can go ahead with ointments which contain 0.1% triamcinolone acetate, like the Kenocort, which is available in India. So the three powders mixed with the Kenocort ointment base would be great enough. Carry it inside the root canal, place it inside the root canal, and then give a temporary restoration of glass enema and let the patient go for 3 weeks. So that's what we did. But this is at the end of the first sitting, triple antibiotic and a glass enema restoration. Patient sent back 3 weeks. And after 3 weeks, when the patient comes back, check for tenderness on percussion, periodontal status, if there are any draining sinus tracts. If any of this are present, you have to repeat the first setting again. If these three things are not there, there no tenderness or no periodontal pockets or any draining sinus tracts, go ahead and irrigate again. This time you do not irrigate it with sodium hypochlorite. You can go ahead and just do a 17% EDTA irrigation. Rinse off all the triple antibiotic paste of the root canal, and then after complete removal, you place PRP inside the root canal. Okay, the PRP is a liquid. It needs to be activated using 10% calcium chloride. Um, well, I'll show you the whole procedure. After PRP is placed, we place a barrier which is collagen, and over the collagen we place MTA, and followed by a double seal with glass enema and composite. So the MTA, glass enema, and the composite make a triple seal over the barrier. So that's what we do for making PRP. That's the old way of blood collection. Okay, that's how you swipe the area in concentric cycles. Uh, Put a tourniquet in, tighten the tourniquet, find the vein. If you're not trained, please get trained on how to do the blood draws. At that point of time, we were using these butterflies. Okay, you have to maintain it there. You can see this blood dripping. That's a very messy process. And then we used to use a syringe to draw. The syringe contains an anticoagulant, which is ACD. That's the best anticoagulant if you're doing PRP-based treatments. Collect 10 cc of blood. That's what we used to do in the early times. But now we have something called the Vacutainer method. It's less messy. Okay, the swiping is wrong. It should be done in concentric cycles. Okay. That's device, right? Get the vein. Right. Here you can see that the blood doesn't spill. Okay. You have a Vacutainer barrel. Just press the test tube inside that. The red color test tubes are normally for platelet-rich fibrin. They do not contain any anticoagulants. For platelet-rich plasma, in this case, we use the green tubes or the ACD-based tubes, heparin-based tubes or the ACD-based tubes. Uh, okay, it just fills up. It has a vacuum inside, around 8 cc or 8.59 cc of vacuum. Once the 9 cc gets occupied, the blood automatically stops. So you have some time to remove. It seals automatically. There's no spillage, no blood contact, clean way. That's how we collect blood these days. Okay, coming back to that case. So we do a double spin in PRP. The first spin is called a soft spin. The second spot is called the hard spin. So there are two protocols here. I'll show you the protocol. So back to the original case, blood draw using a syringe. Okay, it contains an anticoagulant called ACD. That's why it doesn't coagulate here. When you're making PRF, you don't need to mix an anticoagulant. Only for platelet-rich plasma, you need an anticoagulant, right? This is the first spin we're doing at a lower RPM and a lower centrifugal force. This is called the separation spin. We see the RBCs being separated from the plasma. We leave the RBCs down and take out all the plasma. You can see the plasma going off, all the plasma, and a little amount of the red part because they have some platelets at that point. Now we are transferring that whole part into another test tube here, and we're going to spin it the second time. The first spin, we call it the soft spin, which is 20 minutes. The harder spin is at a higher centrifugal force. This is for 15 minutes. So you have 35 minutes it takes to make PRP. So it's quite a laborious, long procedure. The bottom 1 cc in this test tube is PRP. We're going to take this 1 cc out and then activate it with calcium chloride. See, that's calcium chloride inside syringe. We're going to take PRP. So this PRP mixes with that calcium chloride, and once it activates, it takes 5 minutes to gel. So you have 5 minutes to inject inside the root canal. After 5 minutes, this liquid three-dimensionally fills the root canal space and gels. Okay, now you see a collagen membrane or a collagen sponge being placed inside. Then MTA is mixed. That's the MTA plus being mixed. Then it can be carried using a normal amalgam carrier, and then this is packed against the collagen barrier. Over the collagen barrier you place glass ionomer and composite, right? If you don't have resin modified glass ionomer, you can place chemically set glass ionomer, call the patient back on the next day, reduce the glass ionomer by 1 to 1.5 millimeters, then layer it up with normal composite. So that's how it started. This is at 6 months. Don't expect anything to happen at 6 months. By the end of 1 year, you can see the root length increasing, and we could see these root completions by around 2.5, 3 years totally. This was our faculty. So this was this case. This guy was related to one of our faculty, so we could have a very long recall for around 3.5, 4 years. So an effective root completion during that period of time. So to sum it up, whenever do you do this kind of cases, either pulpotomies or regenerative therapies, you should take an informed consent. Uh, you should tell them what the risks and the alternative treatments are. Once all those things are taken care of, the consent is signed, you have to on the visit one give a local anesthetic. Here the local anesthetic can be with a vasoconstrictor on the first visit. Yeah, if you don't want a vasoconstrictor, you can go for a long acting anesthesia. For the first visit, there's no problem, go ahead with local anesthesia with adrenaline. That would be good enough. Proper rubber dam isolation, no isolation, these cases don't really have a good result. The root canals are accessed, working length is determined, and then they irrigated with 0.5 to 1.5 sodium hypochlorite, 30 ml per canal for 5 minutes, minimum of 20 ml per canal. Then irrigated with 17% EDTA. Again, the EDTA volume is high. You have 20 ml of EDTA for 5 minutes. The stay time I told you should be 5 minutes. The end of the irrigation needle should be at least 1 to 1.5 millimeters away from the root end to prevent any extrusion. Side ventral needles are recommended. On the second visit, I told you check for tenderness on percussion, any swelling, sinus tracts, and look for pockets. If none of them exist, go ahead and do the second visit. If any of them exist, you have to redo the first visit again, do all the irrigation again, and then place triple antibiotic paste uh, inside the root canal. So in the second visit, what we do is you perform the clinical examination and then give anesthesia. Here, if you're doing the PRP based procedure, you can give anesthesia with adrenaline. But if you want to do PRP with bleeding initiation from the apical end, like the Nygaard-Osby thing. He created bleeding in the canal by taking a file and going periapically. If you're using this kind of procedure, a procedure we call it revascularization, if you give an LA with a vasoconstrictor, when you poke your endodontic instrument beyond the periapical area, there wouldn't be any bleeding because there's vasoconstriction. So if you intend to initiate bleeding, then don't use anesthetic with a vasoconstrictor. The second, sitting normally, we do combination protocols, put PRP and then initiate beating at the apex. So we use a long acting LA here, 3% mepivacaine. um, Again, the root canal systems are accessed. We do not do any hypochlorite irrigation here. We use 17% EDTA irrigation, remove all the triple antibiotic paste. The canals are dried. Then the PRP is placed like I showed you in the video how it was placed. And then bleeding can be initiated. It is an option. If you want, you can. Otherwise, PRP alone would do. And over the PRP, you have to place a collagen barrier and then at least 3 mm of MTA over that. Okay. The MTA is layered again with glass ionomer and a composite. The case needs to be followed every 3 months, again a 6th month, and after a year, and then every year to a total period of 4 years. The uh, case might respond based on the age of the patient. If you have a 6-year-old, I'm not really a 6-year-old, a 9-year-old or a 10-year-old, you can find results within 1.5 years. But if you are tackling guys who are 25 or 30 years or 40 years old, probably you'll not find these results in 6 months or 1 year. You'll have to wait longer to achieve results in these cases. So can it be easier? Can Because PRP you need to wait for 35 minutes. With PRF again, the membranes being pushed inside the root canal. Oh, it's very difficult to push a membrane inside a root canal. So can it be any easier? Do you have a simpler method than this, which would have shorter processing times and which would be a liquid on injection and convert to a gel within 10 minutes? Yes, there is an option. An option, we call it the iPRF, or the liquid phased concentrated growth factors. These are blood centrifuged in special tubes which are not coated with silica and do not contain anticoagulant. They're spun at proprietary cycles. They have machines which they can do. For the LPCGF, this is the Medifuge from Sulfredent, and for the iPRF, it is the APRF machine from the Shukroon group. So you need to put it in, and after a period of 5 minutes, you achieve a liquid, which we call it the iPRF. It has more growth factors. It is a complete liquid when you withdraw from the test tube. It gives you 10 minutes time. After 10 minutes, it totally converts into a gel, which is an endodontic dream for us. You get a liquid into your syringe, you inject it into the root canal system, and then in 5 minutes you get a three-dimensional gel inside the root canal system. So the iPRF, or the liquid phase concentrated growth factors, would make your life easier in these kinds of regenerative or maturogenesis kind of protocols. So this is the way forward. So regeneration is very simple. You need to practice on how to do the venipunctures, how to get blood out, how to spin the protocols. It's not a rocket science. It can be done by all. We were doing this when we were postgrads. Probably I was in my first year of postgrad, so you can see how much clinical experience I had. So it could work in anyone's office. The main thing is you need proper case selection and proper protocol implementation. If you implement the protocol perfectly, you'll get perfect results. Always you should keep your mind open for new things and challenges, not the routine things you've been following over the period of time. An open mind always leads to innovation. So keep your mind open. And if you see any interesting findings, please pursue your dream. Go ahead and try to do it on a larger group of people. So there are opportunities galore. It's just not endodontic therapies. It's not just root canals you need to do. You can always expand your possibilities with regenerative kind of therapies. So next time you have this kind of situations, think twice before you extract. Save the pulp, save the tooth. Thank you so much. I would be happy to take questions. It was a pleasure talking to you all. So over to you, Saurabh and Anand.
Yes, sir. Yes, sir. Thank you, sir, for a wonderful presentation. We have a few questions, sir.
Yeah.
We have, sir, first question from Neil Doshi. Do we have to prepare the canals or just irrigation would suffice for such lesions and open apertures
Uh,
for PRF?
Yeah, minimal preparation, not those aggressive preparations will do. Uh, just mild scraping of the walls would do it. Most of the necrotic tissue should be got rid of using irrigation. So we are using high volumes here, close to around 30 ml, 20 ml to 30 ml of hypo. So that would take care of it. You got wide canals here.
I Sai sir, can you hear me?
Yeah, yeah.
Okay, I guess Saurabh is lost. Sir, is triple antibiotic therapy predictable for revascularization? This is a question from Dr. Nami Rajput.
Yes, this is a very valid question. I didn't want to get into the scientific articles these days. Yes, there have been articles which have questioned the use of triple antibiotic paste. They say that the higher concentrations would be cytotoxic. So 25 micrograms per deciliter would be fine enough. So you need a pharmacist to make that kind of preparation for you. Otherwise, you can use calcium hydroxide, but the concentration of calcium hydroxide in the paste should be 1 mg per ml. So that's the concentration which is safe for regenerative endodontic therapies. The
So now
beautiful
how to
article
get,
written.
but how to come to that concentration?
You just mix 1 mg in 1 ml of polyethylene glycol. You get polyethylene glycol everywhere.
Okay. Uh, One second. Question from Dr. Vikas Pandey. Putative stem cell therapy for irreversible pulpitis cases. What is the
Hmm.
criteria for case selection?
Stem cell therapies for reverse. See, I would like to tell you the what we are talking about is not stem cell therapies. We're not culturing stem cells here. We are not putting stem cell per se within the root canals. We're using growth factors to home the stem cells into place. These stem cells are within the irreversible pulpitis, the pulp per se. We're trying to signal them. That's it. We're not trying to put any any stem cells into the pulp. Let us make this very clear. I've got participants before. Anand, I've spoken about this to you.
Yes.
We're not doing stem cell therapies. Yeah,
That's a very big misconception that people have always. They
yeah, yeah,
always think directly about the stem cell therapy.
yeah. There is just
Sir,
one
question.
paper.
Yeah, sorry, sir.
There's just one paper on stem cells being used inside the root canals. They achieved amazing results, three-dimensional, but this is still on paper. Uh, Taking it to a dental clinic, it's very difficult to take this practice into dental clinics. It would require operatories with good sterilization, good cleanliness, everything perfect, because the stem cells wouldn't survive. Probably you would need to buy a stem cell preservation unit, which will be more costlier than your clinic per se. Okay, maintaining them at minus 80, it's not a practical thing, taking it from research to chair side. So stem cell therapy, we're not doing it here. We're just signaling stem cells.
Thanks a lot, sir. A few more questions. What is the probability in a tooth with abscess for revascularization? This is a question from Dr. Nilesh Rathi.
Perfect it is. If you put an intracanal medicament and then there is no weeping canals after 3 weeks, go ahead. There have been numerous articles published saying that it works wonders. It doesn't make a big difference. Uh, large periapical lesions. I would say if it's 1.5, 2 centimeters, go ahead and do it. It's not a contraindication.
So one more question from Dr. Neil Doshi. Post-operative pain management after these therapies?
Post-operative pain management is a big thing. I don't want to say after these therapies in any therapy. Endodontic therapies, I say post-operative management is the thing. No pain, all gain. This is the only place where no pain gives you all gain. So you should be using long-acting anesthetics here. Um, you should always prescribe analgesics. I would go with pyroxicams or ketorolacs in these cases. Don't tell your patients take it when there is pain. Always tell them to take it.
Right. Yes, sir. There was one question that which machine do you prefer while making PRF or PRP, sir?
Uh, to be very honest, you can make it with any machine. That's not a big thing. You should
Okay.
program your machines very well to those
Accordingly, right?
centrifugal forces, right?
Specifications.
But if you want
Right.
to have proprietary ones, there are loads in the market, like the Medifuge, like the iPRF, Duo. You can buy them, no problem.
Right.
But you can do it with any centrifuge.
Okay,
Right.
Saurabh, any more questions?
Right. Sir, one more question I had come through across the discoloration if we use a triple antibiotic, especially minocycline. So, sir, I
Yeah.
personally have excluded minocycline, and still I have
Mm.
come across some discoloration in the tooth, very less
Yeah.
compared to the minocycline. So your
Yeah.
inputs, do we have a substitute or a better option alternative to that, sir?
Yeah. Minocycline, yes. Minocycline, two types of discolorations you can see in these cases. One because of minocycline, the other because of the MTA per se. Okay. The newer MTAs don't have these discoloration problems. In your case, Saurabh, must be the MTA is causing the discoloration. From
Right.
minocycline is a beautiful antibiotic. Okay. There is a purpose why you use minocycline, because it has immunomodulatory properties. So how do you take care of that? Is what we do is after the access opening is done, we put a Teflon plug at the orifice level, plug the orifice, and then in the crown portion, we add a layer of dentine bonding agent just to seal off all the
Okay.
tubules, right? Once the tubules are sealed, you will
Right.
never get a discoloration coronally. So that's how we manage that situation.
Got it.
In case you still have a problem, you can substitute. You can remove minocycline. Uh, my preference, if you want to remove minocycline, use ciprofloxacin, metronidazole. A lot of people say cephaloxacin. There's no clindamycin and all that. But what we tell our postgraduate students is to mix it with Kenacort. Kenacort is a zero point 0.5
Okay.
triamcinolone acetate. It can take care of the rank rankle mechanism. It is a very good immunomodulator, a perfect substitute for your minocycline. And you need not run to get polyethylene glycol or propylene glycol. You have a medium to mix. Okay.
Kenacort is there.
Yeah.
Medium to mix. Right.
Saurabh,
Kinacot is
one
it.
interesting question has
Yes.
just popped
Yes,
up,
sir.
sir. If you have time for one more question.
Yeah.
This is a
Yes.
question
Yes.
from Dr. Nilesh Rathi. How do you check the sensibility of the pulp after formation of the apex?
There are
And
1,000
how
articles reporting on the pulp sensibility. and I don't agree with most of them. It is almost not very. It's not possible to get a pulp sensibility test with 3 mm barrier or MTA, and over that you have glass ionomer, and over that you have composite, and getting a pulse sensitivity. I don't know how people get it. Uh, the first case reported on the PRP therapies by Torabenejad, he had told that he got a pulp sensibility test positive, and the patient complained of sensitivity. That's why he went ahead and removed the pulp. Even I had doubts, but there is one researcher from India called Dexton. If anyone knows him, from Kerala, he had written to the Journal of Endodontics saying that it is not possible to get pulp sensibility. And
Yeah.
Torabenejad responded
Right.
saying that probably the way we did sensibility test was not very accurate. So I would go with Dexton and I would go with clinical and radiographic interpretations rather than sensibility test.
Right.
Thanks a lot, sir.
Right.
Saurabh,
Right, sir.
any more questions or we are done?
Yes, sir. No, sir. I think we are done. Such a wonderful session and a new arena in endodontics if we to specify regenerative endodontics. Thank you, sir, for a wonderful lecture, sir.
Thank
Saurabh,
you.
I have a few announcements to make. Thanks a lot, sir, once again for a beautiful session. It was really amazing to listen to you again after all these years. Just one small important announcement to everyone who has been answering the question is, please make sure you put your email IDs correctly. A lot of the responses that we are getting are with incorrect email IDs, so we can't send you back your results. So make sure your email IDs are correct when you enter it into the Google form, and make sure your inbox has some space to accept emails, because many of the emails are bouncing back as saying that the inbox is full. So please take care of these two important things. Thanks a lot. See you again tomorrow on the 26th with the next session with Dr. Pamna Kamat.
Yeah, don't miss that.
Yeah, surely. Bye-bye, sir.
Yeah.
Take care. Good
Thank you,
night.
sir.
Bye-bye,
Good
Dr.
night.
Saurabh. Bye,
Good night.
everyone. Good night. Good night.
Thank you. Thank you. Good night,
Thank
sir.
you. Good night.